Good morning, students. Today we have a new subject. It is the diagnosis and surgical management of common jawbone diseases. They are divided into two categories, the odontogenic tumors and non-odontogenic tumors. In the current lecture, we are dealing with the odontogenic tumors. It is divided into two sections. Section 1 we'll take it this week, and section 2 we will take it next week, God willing, because it is a long and important subject, and I wanted to give it its right. The term odontogenic refers to as anything that is derivative from a tooth-related apparatus, like odontogenic cysts, odontogenic infection, or the subject of today, odontogenic tumors. Tooth formation is a complex process involving both connective tissue and epithelium. Why this is important? Because these tissues are considered the origin of the odontogenic tumors. The odontogenesis have three major tissues involved: the enamel organ, which is derived from the oral ectoderm, the dental follicle, and dental papillae, both considered an ectomesenchymal in nature. Previously, the term ectomesenchyme was named mesenchyme because it was thought it is derived from the mesodermal layer of the embryo, but now it is thought it is a tissue differentiated from the ectodermal layer of the cephalic portion of the embryo. So the term is ectomesenchyme. Why these terms are important? The ectomesenchyme and the epithelium, as I said, because they are the origin of odontogenic tumor. According to these tissues, we will classify the odontogenic tumors. So, what are the odontogenic tumors? Odontogenic tumors represent a diverse group of lesions of the jaw and overlying soft tissue. So they are not only specifically present in the jaw, they also may be present in the gingiva. Odontogenic tumors share two major characteristics. First, they arise from tissues with the potential to differentiate into tooth or periodontal structure, which is these tissues are exclusively found in the jaw bone, in the maxilla and mandible. So they are specific tumors. The second characteristic is the formation of tooth-related extracellular substances, which might calcify and be visible in the radiograph. Some tumors, they may have enamel deposits, some have cementum deposits, which in the radiograph will appear as radiolucent mass mixed with radioepic points, which are the calcifications. From where the odontogenic tumors will arise, or the sources of formation of odontogenic tumors. They may be derived from enamel epithelium, of the tooth, namely the reduced enamel epithelium. They may be derived from epithelial rest of molasses, all or the rests of series, which are remnant of dental lamina. They may arise from the tooth germ itself, including the enamel organ, the dental papillae, and dental sac. They also may arrive from the basal layer of the oral mucosa. This is the oral epithelium. This is the basal layer of the oral mucosa. It is facing the tooth when it is during facing the tooth or odontogenesis. So they may arise from the basal layer of oral mucosa or from the lining of odontogenic cysts. Some tumor arise from the lining. The classification of odontogenic tumors according to the World Health Organization, this is the latest classification during 2017. It classified the odontogenic tumor into benign and malignant tumors. The benign odontogenic tumors are subclassified according to their tissue origin into three subcategories. The first subcategory is epithelial odontogenic tumors. They are tumors derived from the odontogenic epithelium. Like what? Like amyloblastoma, calcifying epithelial odontogenic tumor, squamous odontogenic tumor, adenomatoid odontogenic tumor. The other subcategory is mixed epithelial and ectomesenchymal odontogenic tumors. They are consisting of both epithelial and ectomesenchymal odontogenic tissues, with or without dental hard tissue formation. Like in odontoma, we can see deposits of dentine, deposits of enamel inside the tumor. In case of compound odontoma, we see tooth-like structures. In case of complex odontoma, we see a mass of dental hard tissue, a mass of enamel and dentine. The third subcategory is the ectomesenchymal odontogenic tumors. They are tumors derived from the ectomesenchymal tissues, with or without odontogenic epithelium. This odontogenic epithelium has no essential role in their pathogenesis, so we cannot say they are mixed. They are not mixed. In the mixed epithelial and ectomesenchymal, both epithelial and ectomesenchymal odontogenic tumors have neoplastic properties. In the ectomesenchymal odontogenic tumors, if we have odontogenic epithelium, it doesn't show any neoplasmic changes, like odontogenic fibroma, odontogenic myxoma, cementoblastoma, and cemento-ossifying fibroma. The subject of today's lecture will be the epithelial odontogenic tumors. And in the next lecture, next week, God willing, we will take the other subcategory. The malignant odontogenic tumors are classified into odontogenic carcinoma. The carcinoma means these tumors are derived from the epithelium, and in this case from odontogenic epithelium, so they are called odontogenic carcinoma. Odontogenic sarcoma means these tumors are derived from connective tissue. So when we say odontogenic sarcoma, they are derived from the connective tissue, from odontogenic connective tissue, like the bone, like the periodontal ligament. Odontogenic carcinosarcoma, they have both neoplastic and malignant epithelium and malignant connective tissue. They have both types of tissues, and they are both have the malignant features. As I said, the malignant odontogenic tumors also, we will discuss them in the next lecture. Now, the process of diagnosis of odontogenic tumors. On what basis I will say this is an odontogenic tumor, this is like amyloblastoma, or this is the odontoma? On what basis I will base my diagnosis? First, the clinical information about the age, the race, the sex of the patient, the clinical features of the lesion, the duration of the lesion, any accompanied symptoms like pain, swelling, paresthesia, loosening of teeth. All these will be helpful. After this, we will take radiograph. As they are odontogenic tumors, they mainly occur in the jawbone, so we must take radiographs. Mostly we take OPGs, and if the OPGs are not didn't give us enough information, we may take CT scans or MRI. These two steps give us information but not enough information. The step that will give us a definite diagnosis of odontogenic tumors, it is the histological analysis done by taking biopsy. The biopsy in case of odontogenic tumors has a key role in the diagnostic process. It is an important tool in the diagnosis of odontogenic tumors. The biopsy could be incisional, excisional, or intraoperative frozen section. Like during the operation, I decided to take a specimen, frozen specimen from this lesion. I take a specimen and then freeze it, and then send it to the lab, do sectioning on the frozen section, on the frozen specimen, and give us the definite diagnosis. So the histological analysis, mainly the biopsy, it is an important tool in the diagnosis of odontogenic tumors. So after this, I will combine all the clinical, radiographic, and histological analysis to reach a definitive diagnosis and to prevent over or under treatment. Like, sometimes in case of amyloblastoma, we say I'll do only inoculation. But if I do a biopsy and see this amyloblastoma is a malignant amyloblastoma that have metastasized or have the potential to metastasize, then resection is important. So sometimes I may be do under treatment for a dangerous or malignant tumor if I don't know what is the specific type of this tumor. Or maybe it is a simple tumor like cementoma, doesn't need any resection of the bone, and I do resection because I didn't do the histological analysis. All these factors are important in reaching the diagnosis of odontogenic tumor. Now, what are the surgical steps or the surgical management of odontogenic tumors? The surgical management are made easier by the fact that many odontogenic tumors behave similarly, so they can be treated in similar manners. We have two main modalities for surgical excision of the tumor. It is either inoculation or resection. These are the two major surgical modalities for treatment of odontogenic tumors. What is inoculation? It is the local removal of a tumor by instrumentation, where the instruments are in direct contact with the lesion. Used in a variety of benign odontogenic tumors. Sometimes with the inoculation, I will need to do a curettage. Here, what we mean by curettage is mean that after I removed the tumor, the soft tissue tumor, this is the cavity. The curettage means that after inoculation, I bring my curate or a bear and remove 1 to 2 mm of bone all around the periphery of the cavity that is left by the odontogenic tumor. This is the curettage. When I do this, when I suspect there is remnant of soft tissue in the cavity of the tumor. This is inoculation. It is simple. It is the main treatment for benign odontogenic tumors. What is resection? Resection is what we say a more aggressive type of treatment. Resection, it is the removal of a tumor by incising through uninvolved tissue. In the inoculation, the instrument was in direct contact with the tumor. Here, I will be not in direct contact. I will be in unhealthy tissue and resect normal tissue along with the tumor. Do resection of normal tissue along with the tumor. Delivering the tumor without direct contact during instrumentation. I didn't have any direct contact. Why? Because I'm working away from the tumor, taking the health tissue all around it. This resection also called in block because I take like a block of bone. Resection have several types. First, we have the marginal or segmental resection. Here, the resection of a tumor without disruption of the continuity of the jaw. Here, I'm leaving the inferior edge of the mandible intact without any breakage. So I'm removing the tumor above the inferior border of the mandible, leaving the mandible intact without any breakage. This is called marginal or segmental, only taking the margin of the bone or segment of the bone. Partial resection, like we see in here and here, I am taking a section, partial section of the bone. So I'm causing disruption of the continuity of bone. Here I'm taking a full thickness bone. Here I'm taking, I took a partial thickness of bone. I left the inferior border intact. Here I'm taking a full thickness of bone. Here also, a full thickness of bone, like in hemimandibulectomy. So, in these cases, the jaw continuity are disrupted. The other type of resection, it is called total resection, complete removal of the jaw, like maxillectomy or mandibulectomy. Here we are taking the whole half of the maxilla, removing the entire maxillary bone, like here the entire right maxillary bone, maxillectomy. In composite resection, which is the fourth type of resection, here we do resection of the tumor with the bone, with the adjacent soft tissue, with the lymph node canals. This is this type used mainly in case of malignant tumors. The composite resection used mainly for malignant tumors because it is spread widely. Because of its spreads widely, it is not only contained in the bone, it's only, also in the soft tissue and the muscles and the in the lymph nodes. These are the basic surgical operations that we will see during our journey in odontogenic tumors. Many benign tumors behave non-aggressively and therefore treated conservatively. We need a conservative treatment for them. So we do inoculation or sometimes only curettage or sometimes a combination of both. Another group of benign tumors behave more aggressively, even if they are aggressive, but they are still benign. The cells doesn't have malignant transformations. These groups may need more aggressive treatment like marginal or partial resection. In the last group of tumors, which are the malignant tumors, these tumors require intervention that is more radical, with wider margins of uninvolved tissue. So composite treatment, composite resection is the treatment of choice. Sometimes with the resection we need radiotherapy or chemotherapy, sometimes in combination with the surgery, sometimes alone without surgery for their treatment. Now we enter to the subject of our lecture today, which is the benign odontogenic tumors. First of all, we have tumors of odontogenic epithelium. Their origin tumors with their origin from odontogenic epithelium. The most common one, it is the amyloblastoma. It is the most clinically significant odontogenic tumor, and it constitutes 14% of all jaw tumors, which is a high percent. These tumors may arise from rests of dental lamina, developing enamel organ, the epithelial lining of odontogenic cysts. That is why it is important, if we encounter any odontogenic cyst, we remove it completely to prevent any formation of any tumor from the lining of the odontogenic cyst. And finally, the basal cells of oral mucosa. All these are possible sources of amyloblastoma. Amyloblastoma, why it is important? Because it is locally aggressive, which means it infiltrates into the bone. That's mean locally aggressive. It infiltrates into the bone. About 70% of the cases undergo malignant transformation. That is why amyloblastoma is dangerous, because it have a high probability of malignant transformation. And from this malignant transformation, about 2% metastasize to other sites. Amyloblastoma have 3 different variants. Why we will discuss them separately? Because each have a specific implication for treatment and have a unique prognosis. The first variant of amyloblastoma is solid or multicystic or multilocular amyloblastoma. It consists about 91% of all cases of amyloblastoma. So this is the most common type of amyloblastoma. It is encountered over a wide age range, rarely seen in children in their first decade of life, and relatively uncommon in the second decade. The tumor shows relatively equal rates of occurrence in the 3rd through the 7th decade of life. The males are more affected by this tumor than females. It is located in about 85% of the cases in the mandible, in the molar and ramus region, as we see here. As we will see, about almost most of the cases of odontogenic tumors are seen in the mandible. It is appeared as a painless expansion of the jaw, a slowly growing painless expansion of the jaw. The neurosensory changes are uncommon even with large lesions, which means we don't see the patient complaining from paresthesia or pain. The slow growth of lesion if untreated, lead to a tremendous facial disfiguration, as we see here. The most common radiographic feature, it is The multilocular radiolucency, as we see here, it appears as multiple cysts, so it's called multilocular radiolucency, with buccal and lingual cortical expansion, even perforation of the bone, resorption of the adjacent teeth also common. Amyloblastoma is both highly aggressive and curable, and the treatment is ranging from simple inoculation and curettage to more complex resection. The amyloblastoma has the tendency to infiltrate between intact cancellous bone trabeculae at the periphery of bone tumor, and often extend beyond the apparent radiographic or clinical margin. Like in here, I see this is the margins of the tumor, but sometimes during surgery when I open, I see that the lesion is entered here in the trabeculae. So it is so the borders of the lesion in the radiograph does not have, especially in the multicystic amyloblastoma, does not have the correct boundary. During surgery, I must take great care in deciding where is the boundary of the amyloblastoma. Therefore, the removal with a curate will leave some islands of a tumor which then lead to recurrence. So, in these cases, due to its high infiltrative and aggressive nature of the multicystic amyloblastoma, the treatment should be resection of the tumor with 1 centimeter linear bony margin, which means I don't take only the lesion, I take 1 centimeter, not 1 millimeter, no, I take 1 centimeter of intact bone. So in this case, we will do a partial resection. I will resect the bone here and here. Of course, after resection, we will put metal mesh or metal bars and do reconstruction and bone graft for the patient, so he will not go without any bone. This is the surgical treatment for amyloblastoma. The other variant of amyloblastoma is unicystic amyloblastoma. It occurs in about 8% of all cases. It's mostly seen in young patients. The mean age of the patient of unicystic amyloblastoma is about 26, while the mean age of multicystic about 40. So this gives us a little diagnostic information about the tumor that we have. Also, we have the male are more affected than female, even though the picture that we have here is for a female patient. Mostly seen in the mandible, especially in the molar and ramus area, as we see here. Also, so both types that we have here, the multicystic and unicystic, are appeared in the posterior area of the mandible. Radiographically, they appear as a radiolucent mass, like we see here. It's a radiolucent mass. No trabeculae appeared, no multiloculation. Unilocular radiolucent mass. It is like a dentigerous, like we see here. It's like dentigerous, even especially if it is associated with an erupted tooth, which is sometimes may occur. Like we see here, it causes malpositioning of the lower 8. And we see here it appears as the unicystic amyloblastomas have 3 histological variants. These variants have an importance in the treatment, in choosing the proper treatment, and in the prognosis of the case. First, we have the luminal, this number 1, luminal amyloblastoma, unicystic amyloblastoma. It is confined to the luminal surface of the cyst. I forget to say the unicystic. Why it's said unicystic? Because it is like a cyst. Like a cyst, it have a space inside it, and the amyloblastic tissue are around it. So in the luminal, the amyloblastoma is confined to the lumen of the only to the lumen of the cyst. The lesion consists of fibrous wall with lining that consists totally or partially of amyloblastic epithelium. So it is confined only to the luminal wall. Intraluminal unicystic, which contain one or more nodules projecting from the cystic lining into the lumen of the cyst. This like nodules project into the cyst. This is the intraluminal. These nodules may be small or large, that sometimes may fill or the cyst. The third type, it is the mural unicystic amyloblastoma, which is the fibrous wall which occur in the wall. The fibrous wall of the cyst is infiltrated by typical follicular or plexiform amyloblastoma. The extent and depth of amyloblastic infiltration is variable. It sometimes may be all the way to the outer layer of the fibrous wall, or sometimes only partial thickness. So, the treatment and the prognosis for this type of amyloblastoma, the unicystic blastoma, as we said, is determined by these 3 different variants. First of all, the treatment of luminal or intraluminal variant of unicystic is inoculation and curettage. Simple inoculation and curettage is that all the treatment we need for the case of luminal and intraluminal, because during inoculation I will remove all this tissue. I don't have any fear that this amyloblastic tissue are in contact with the bone. The amyloblastic tissue occur inside the cyst. So I have no fear of leaving any amyloblastic tissue. The recurrence is about 10 to 20% following inoculation and curettage, which is considered a low percentage. Which is this considered a low percentage than the when we do inoculation and curettage for the multicystic amyloblastoma. So when we do resection for unicystic. Yes, we do resection for unicystic. What are the cases that we do resection? First, recurrent unicystic amyloblastoma. In the case of recurrence, a tumor recurs following a well-performed inoculation and curettage should probably approach with a more aggressive resection. So if a patient first time he came, I diagnosed the lesion as unicystic. The first time I do inoculation, he returned to me the second time with the same lesion in the same area, I will do resection. The second instant that we do resection is the case of a mural variant of Unicystic Amyloblastoma. This variant is probably more aggressive than the luminal and intraluminal. Why? Because it infiltrates the fibrous wall, so it may be enter to the bone. It will be in contact with the bone. The amyloblastic tissue will be in contact with the bone. It seems logical to approach this tumor with surgery similar to multicystic, which means we do resection in case of a mural. The third instance that we do resection is the management of large tumors with significant expansion. If we have a very large tumor and he causes a significant expansion, we do resection of the involved jaw. The other type of amyloblastoma is peripheral or extraosseous amyloblastoma. It encounters in about 1% of all cases of amyloblastoma, so it is a rare form of amyloblastoma. It occurs over a wide age range with average age about 52. Also, the male more affected than female. Its location, it occurs in the mandible more. As we will progress in the discussion of tumors, we will see the most affected part is the posterior region of the mandible. And almost most of the odontogenic tumor occur in the posterior region of the mandible. Clinically, the lesion will appear as non-ulcerated exophytic mass or exophytic gingival lesion, approximately less than 1.5 centimeter in size. The radiograph, as it is extraosseous, so there will be no changes in the radiograph. This case is the same. This radiograph, it is the radiograph or this case. We see here it occurs in the area of the premolars. Here are the premolars. There is no any change in the radiograph. So in the radiograph, we see no signs of the lesion. The treatment of this type of amyloblastoma is treated by wide local excision. Which means we take the lesion along with a wide margin of healthy tissue. When the surgical margins are negative, an important point we must say, after we do resection or inoculation of the tumor, especially after resection, we send these specimens to the library to confirm that the margin we took are healthy. These margin don't have any tumor lesion. Any lesion. These margins doesn't have any lesion. This is an important point. After each resection, I send the specimen to the laboratory to confirm the margin I took are negative, which means doesn't have any, which means the margin doesn't have any neoplastic tissue. If we confirm this in any case, in any one of the cases that we discussed previously, in the case of amyloblastoma, the recurrence will be a less like consequence. يعني كلش نادر راح يصير عندنا. We have another type, a rather dangerous type of amyloblastoma. It is metastasizing amyloblastoma, which is the malignant form of amyloblastoma. It is an extremely rare entity, consists of histologically benign amyloblastoma but with a metastatic behavior. Mostly, the metastases occur to the lung, but less frequently to the bone marrow and the brain. The metastases usually follow multiple local recurrences of the original tumor. We have benign amyloblastoma. We do curettage or inoculation and it recur. We do another inoculation and recur multiple times. It will lead to the development of malignant amyloblastoma and it will metastasize, which means we will find the amyloblastic tissue inside the lung, mostly in about 85% of the cases metastasize to the lung, and sometimes we see their metastasis into the bone marrow or to the brain. How this metastasis occur, or how this amyloblastic tissue will travel? It will travel through the hematogenous route, through the blood, or the lymphatic route, or erogenous, which means the patient inhale the amyloblastic tissue, so it will enter to the lung and proliferate, or from passive transplant secondary to surgical manipulation. If we do surgical treatment and the instrument all have amyloblastic tissue, and if it touch another tissue, it will lead to passive transplant. It will lead to metastasis to this tissue. Like if we puncture the gum, or puncture the lip, or puncture the tongue with a scalpel that have amyloblastic tissue, this will lead to metastasis to these areas. Instances of metastasis are seen mostly associated with multicystic amyloblastoma rather than unicystic. Like we say, the multicystic have the ability to infiltrate through the trabeculae of bone. They are more aggressive than unicystic, so they have more malignant or more metastasizing ability than the unicystic. And in the histological examination, they are indistinguishable from the conventional, which means this metastasizing amyloblastoma or the metastasized tissue are similar to the normal benign amyloblastoma. So it is important to regard all amyloblastoma as potentially malignant when we plan their surgical management. So we do definite excision rather than we procrastinate and do inoculation for the sake of it is less aggressive. No, amyloblastoma, it is an aggressive, even if it is benign, but it is an aggressive tissue with high potential for malignant transformation, so we must approach it with an aggressive line of treatment. Like we see here, this is an elderly patient that have a malignant amyloblastoma. Here we see the expansion of the bone. Here in the MRI, we see this is the malignant lesion. Another benign odontogenic tumor of odontogenic epithelium is calcifying epithelial odontogenic tumor or Pimborg tumor. This is an uncommon lesion, account for less than 1% of all odontogenic tumors, mostly encountered between the ages of 30 and 50, usually located in the mandible, as we said, and as we will see, most of the odontogenic tumors are located in the mandible. The clinical presentation is a painless, slow-growing mass. This is also a common feature of most of odontogenic tumors. Radiographically, the most common presentation is a mixed radio-opaque and radiolucent lesion. This is the radio-opacity and radiolucency, often associated with an impacted tooth. This lesion here associated with an impacted lower premolar, lower 5. The treatment for this type of lesion, although it is a slowly growing lesion, but it has a highly infiltrative and destructive ability, and it is able of an aggressive behavior. So it is recommended to treat this tumor like we treat amyloblastoma, which means marginal resection with 1 centimeter bony linear margins, which means we do resection, marginal or segmental resection with 1 centimeter of clear area, clear bone around it. And as we said, when we take the specimen, we send it for the histology, for histological analysis, to confirm that we have removed all the tumor. How? By confirming that we have a normal bone all around the lesion. Another benign odontogenic tumor of odontogenic epithelium is the squamous odontogenic tumors. This rare tumor usually seen in adults over a wide age range, ranging from childhood to the 18th decade, and slightly more predilection towards male. The most common site of the lesion is usually in the mandibular posterior area and in the maxilla and the anterior area. Clinically, it appears as a slow-growing intra-bony lesion with very signs and symptoms. The patient may come to the clinic for checkup or for any other problem, and we took OPG and we see that the patient have a lesion, because this is mainly intra-bony lesion with a little expansion of the bone. Some of the complaint usually is mobility of the teeth adjacent to the lesion. As we see here, these teeth are floating in the mouth, so they are not supported by bone, so they appear mobile. Also, we may see the patient may complain mild to moderate pain of the affected area with slight swelling in the alveolar process. Radiographically, it have a characteristic unilocular triangular shaped radial lucency. As we see here, this is the triangle and this is the wide base between the divergent root. This is the divergent root forming the wide base of the triangle. The treatment for this type of lesion is conservative treatment, usually by surgical excision, which means removal of the lesion only, and usually considered as a curative and rare episode of recurrence occurred. So normal excision, which means inoculation, is simple treatment, conservative treatment for this type of tumor. The final type of benign odontogenic tumor of odontogenic epithelium origin is the adenomatoid odontogenic tumor. This tumor represents about 3 to 7% of all odontogenic tumors, which considered a high percent. It is limited to young patients. 2/3 of the cases are reported between the ages of 10 to 19. Female are affected twice more than male. So here we see the female more affected by this lesion. The location of this lesion usually in the anterior section of the upper or lower jaw, and often related to unerupted canines. As we see here, this is an unerupted canine, and this is the adenomatoid odontogenic tumor. Clinically, it appears as asymptomatic, slowly growing volume, often related to an unerupted canine, as we say, in the gingival region of the upper or lower jaw of patients between 8 to 19 years old. In the radiograph, we will see a well-defined, well-circumscribed area that is associated with the crown of impacted canine. We see also displacement. We see heel displacement and malposition of the teeth, and also causing root resorption. May cause root resorption. The treatment and the prognosis for this case, due to their non-invasive characteristic and slow growing, as well as the presence of capsule, which means these tumors have a fibrous capsule around it, so they respond satisfactorily to a conservative treatment, which means simple inoculation and curettage is all the treatment that we need. Without recurrence, without any episodes of recurrence. An important note to keep in your mind. هسه هنا قد شفنا كيسات مال OPG. لما تجيك هيجي كيس OPG ويقول لك تعال فكر لي أو تعال قل لي هذا يا تيومر أو هذا يا سيست. أنت هنا دا تشوف فيها دا تشوف هذا البيشنت يونغ، فتجي تفكر شنو هي التايبس اوف تيومر او التايبس اوف سيست اللي ممكن تصير باليونغ ايج واجي اعددها. مثلا بالعكس اجي اشوف كيس البيشنت كل سنونه شالعها، معناها شنو هذا اولد ايج، ابدي افكر شنو هو التيومرز او شنو هي السيست اللي ممكن تكون بالاولد ايج. فهاي نقطة أخليها ببالنا، إنه أنا من أباوع الأو بي جي مو بس أباوع الليجن، أباوع شكو فيتشر ممكن تكون. لكن مثلا هنا البيشنت قلنا يونج ايج، بعد البرايمري عنده وبعد البيرمننت بعدها دا تطلع. أباوع إذا عندي impacted، أشوف أكو ليجن associated with the impacted أو لا. أباوع الإيرياز مال ماندبل، إيرياز مال أنجل، خاصة إذا عندي مثلا 8 أكو associated with it any lesion or not. فهاي شغلة كلش مهمة أخليها ببالنا. طبعا هذا الحكي يعني يفيدكم كان مثلا بالامتحان الأورالي يعني، بس هسه راح يصير الامتحان الإلكتروني والله كريم، بس هم هاي نقطة تفيدكم إن شاء الله تستفادون منها. Thank you.